saying that I also don't owe anything to the drug companies. My disclaimer is that I'm not in recovery unless you count tobacco, which I guess you can count that. But so my perspective is not a direct perspective that some of the other speakers have had. But I do work at the Victoria Detox, and I've worked there for a number of years. And now I work 10 days a month. I go in and I admit 4 or 5 patients a day and discharge about the same number and get a chance to talk to lots of the others. So I hear lots of stories and lots about people's experiences with the healthcare system, with their family doctors. And I realized as Ray was talking, I think at least half of the patients that I see are in that 0.6%. So because we have a lot of people who cycle through detox, unfortunately. But I also have a window on recovery because I see people who have been in very good recovery but unfortunately suffer a relapse and end up coming in after sometimes 10, 20 years of recovery, and they come into detox, and hopefully that's the impetus to get them back on track. So basically what I want to do, Ray has actually taken almost all of my talking points, and I had one left. I was going to talk about compassion, but Steve just took that too. So I had a music teacher once who told me that repetition is the spice of life, so here's where we're going with this. Family physician's role in addiction. Let's go. Now, is this going to work? It's not working. Let me try that. Okay, so talking to patients, what kind of things do I hear from patients? They say, I don't think my doctor knows much about addiction, and sometimes they're right, and it's not our fault. We weren't taught anything about addiction. We have to really work to find anything out. My doctor's fed up with me. This is what patients think. I think this speaks a little bit to some of the shame that Jackie was talking about. I don't talk to my doctor because he knows my whole family. They're really concerned about confidentiality. And I hear stories, patients saying that, you know, my doctor did talk to my mother about my condition. I felt like I was being judged, and that's a big one. So these are the things, and we've heard sentiments about this from some of the other talks. But it's not all negative. They also say my doctor's very supportive. And some say, one said, my doctor doesn't seem to know much about addiction, but they call the specialist for advice, and I like that. And strangely enough, this was a patient talking about the same doctor that was on the other slide, where she said, my doctor doesn't know much about addiction. Different patient, same doctor, and it shows that it really helps for the patients to know that you care enough to make a phone call. My doctor and I have worked out a plan. Someone came to detox, and they had already been working along with their doctor. They knew exactly what they were going to do when they get out, and hopefully that's what we're all going to be able to do once we're finished here today, is work with our patients on a plan like that. And I want my doctor to be involved in my care. So that's what patients say. So what do you think doctors say? They say, I feel I'm out of my depth. I've run out of ideas. I get a chance to phone doctors when I'm discharge planning and talk to them. Sometimes I try to convince them to prescribe Suboxone. And so these are some of the sorts of answers that I get. My patient has been lying to me. I don't think I'll be able to trust them now. We're going to talk about that lying behavior and what motivates that and how we can deal with it. This patient usually misses their appointments, and I don't have time to take on anything else. This was from another physician I asked about prescribing Suboxone, and I understand. You know, I did full-time family practice, and I didn't have time to do anything else. I couldn't have imagined it then, and I don't know. My hat's off to people who actually take this on now. And I want to ask for another show of hands, actually, of people who are prescribing Suboxone who aren't already methadone prescribers and who don't work at Kool-Aid Clinic. So how many then are there? Hands up high. So 1, 2, 3, 4, 5, 6. So that's the real number of brave souls who are doing this with just a very few patients in their practice. Okay, so let's see. Now nothing's happening. Oh yeah, okay, this is outline of the talk. So I'm going to do a couple of definitions. talk about a couple of tools that I think are important to know about, and then some general words about communication, relapse prevention, recovery supports we've seen a lot in the back, and we're going to have a talk about, and then the use of medications to support our patients in recovery. So this is the definition of addiction from NIDA, and it's defined as a chronic relapsing brain disease characterized by compulsive drug seeking and use despite harmful consequences. This definition lacks the dimension of craving, which is the other quality that's in the DSM-5 criteria for addiction. And Ray made the point, and I wanted to just really drive it home, that we have to manage this as a chronic disease, just like diabetes or asthma. It has all the qualities of a chronic disease. It never truly goes away, and we have a big role to play in setting out a plan of monitoring how people are doing and following them through different stages. And we'll get back to that. I know the other thing I wanted to mention about a practical thing. A lot of physicians I've spoken to don't realize that they can bill for having patients in their practices who are in recovery or in active addiction. So you can write a mental health plan for these patients and bill the chronic disease management fee that goes along with that. Is there anybody that didn't know that? Yeah, so okay, so there, you two people have just increased your income because of coming to this, and I think it's helpful if people create a registry in their practices of who in their practice is in addiction or is dealing with addiction, either in active addiction or in recovery. And I would encourage you to consider that, maybe even make notes while you're thinking of this if you're reminded of a patient. So a definition then of recovery, and this is the definition from the Substance Abuse and Mental Health Services Administration. It's very similar to what Ray talked about, that involves improving health and wellness, living a self-directed life, and striving to reach full potential. Improved health and wellness is what we do. I mean, that's our job as physicians, and so that's something that we can work on with people in recovery. The question comes up, how do you identify who in your practice is in recovery? It's easy if they've just been discharged from detox, or they've just come out of Cedars, you know that they're in recovery. But a good 25% of people, like Andrea, never seek formal treatment. So you won't know unless you ask, and Ray made the case for screening, and I want to make that again as well, that it's important to screen for the use of drugs and alcohol. And if the patient says, no, I don't use those things, well, then ask the question, have you ever been concerned about your use, or did you ever use, and have you changed your pattern of use? And if somebody says, I don't drink alcohol at all, in our society that's somewhat unusual, and it often speaks to either a past growing up in an alcoholic household so that they've made the decision to never drink, or they may have drunk to excess in the past themselves. So it's important to ask those questions, and if you ask those few questions, you may discover there's more patients in your practice in recovery than you thought were there. So now I would like another show of hands. Who in their training was taught something about the stages of change model in their training? Okay, so there's quite a few who didn't. Okay, have people since they trained learned about this model? Yes? Yes, yes, yes? Okay, so most people I think are familiar with it, and I'm not going to go into it in any great detail. Just to say that, I think it bears reviewing, because obviously it's very important in the whole area of addictions. And it's good to be reminded of it, because it applies to so many other things that we do as family physicians. It applies to, we could make a long list, but eating behavior, exercise behavior, compliance with medications. Anybody? I'm trying to think of other things, but there's lots that would fit into this sort of model. And the stages are pretty self-evident. People go through these stages. From pre-contemplation is when somebody is in the addiction model, that they're in active addiction. They're not thinking about changing their behavior, and then something may happen, comment from a family member, or they suffer some adverse consequences from their use. They're in a contemplation stage. They move to preparation, action stage, and when they get into recovery, they'd be considered in the maintenance stage. And this model makes use of the fact, or points out the fact, that relapse is part of the process. People can relapse and then sort of get back on the wheel. So an example of this, just to make something concrete of it, I'll use myself as an example. I'm not in recovery from substance use, but normally when I'm in maintenance stage, I like to exercise regularly. But when the weather gets bad, or if I get an injury, I stop exercising and I relapse to general sloth and inactivity, and sometimes right into the pre-contemplation stage again. And this winter I was in Mexico changing into my bathing suit, and I got a sideways look at myself in the mirror, and suddenly I'm in the contemplation stage. So that was like in AA they talk about a moment of clarity. So that was my moment of clarity, and I spent the rest of the vacation preparing to get back into action and back to my exercise program. So that's the way the stages of change can work. And then it remains to be seen whether I'll relapse again and see if I learn from my relapse. Now, this is only a model. People don't progress from one stage to another in a neat fashion. There's criticisms to this model. It doesn't take into account a lot of external factors. It's a model about motivation, but change involves motivation, and it involves having the ability to make the change, having the ingredients you need. So a homeless person, it's pretty hard to fit into this sort of model, for example. And so the next tool is motivational interviewing. And again, who learned motivational interviewing in their training? Not many at all. Has anybody attended a workshop on motivational interviewing? Again, let's just see. So about half, okay. And who thought that was a really valuable thing to do? Yes, okay. Everybody who attends an interview, a workshop on motivational interviewing, walks away glad that they did. And this is one point I want to make. If you have the opportunity to attend a workshop, please do. If you don't have the chance to do that, there are a huge number of videos on YouTube that explain motivational interviewing, lots of examples. One of the resources that's in your package is the Center for Addiction and Mental Health website in Toronto, and they have a family practice toolkit, or primary care provider toolkit, that has some information about motivational interviewing and some really nice videos done by Peter Selby in Toronto that demonstrate the use, talking to people about substance use. So motivational interviewing, you can read the definition there. Essentially, it's a way of talking to people to help them make changes that they already want to make. And it begins with the assumption that ambivalence is normal. It's normal for people to have two conversations going on in their head about whether they want to make a change. Now, this is particularly useful in trying to get people to engage in treatment, but it continues to apply later on, because when someone's in recovery, they have to make so many changes that it's still helpful to have a framework for helping them to, to build motivation and to make those changes. An example would be to get into recovery. Somebody, often what they have to do is get rid of most of their friends, all their using friends. And they may be ready to stop using substances, but may not be ready to make that change. But there's a part of them that knows that has to happen for them to really get better. Just getting back to the stages of change model. The other thing, one point I wanted to make about that is people can be in the action stage for one substance. They can be ready to quit drinking, but they're still pre-contemplative about smoking pot. They're still pre-contemplative. They're almost always pre-contemplative about stopping smoking. And that's somewhere else that we can work with them, and we can remember that there's other things going on besides the primary drug of choice. So motivational interviewing, just a couple of, just a quick outline of the basic concepts of motivational interviewing. I couldn't begin to teach it to you. I'm not really qualified. I'm sort of a neophyte myself, but the basic spirit of motivational interviewing, it's taught in this way that there are these 4 components to it. It's rather than being a top-down thing where you give advice to your patient, which is what we were taught to do in medical school. We know the information, we impart it to patients, and then they do what we say. But this is, you form a partnership with your patient. The idea of acceptance is acceptance of the patient. It's meeting them where they are at this time, and I think Jackie mentioned that. Compassion sort of goes without saying, but it's easier said than done, and I'm going to talk about that a little bit later. And the idea of evocation refers to working to draw out the patient's own thoughts about their motivations and the changes they want to make. This is this and the stages of change. I think people, when they start using these frameworks to deal with patients, it can be extremely liberating to realize that you don't have to fight with your patient to do what you think they should be doing. The core processes of motivational interviewing, open-ended questions, we all know about that. Affirmations is letting the patient know that that they're a person of worth, that you value them, and recognizing them for the hard work that they're doing. Reflective listening and summarizing are 2 other skills. And when you take a course in motivational interviewing, it's usually done in the format of a workshop over a couple of days. You learn how to roll with resistance. And this saying, it's a dance rather than a wrestling match. The workshop I attended a couple of years ago, there was a physician sitting at my table, and he was a bit crusty when he started the workshop, and he was not sure this was going to be worthwhile. But he listened carefully, and he went away to his practice, and when he came back, he said he'd had the best day that he'd had in his practice, in his clinical practice, in 12 years, because instead of fighting with his patients, he danced with them. Okay, so he learned how to not get into that confrontational sort of attitude. And so, again, strongly encourage you to consider doing more work in motivational interviewing. There's the Center for Collaboration, Motivation, and Innovation, which I put the reference in your reference package. They offer courses. There's the online resources I mentioned, and the CAMH Primary Care Toolkit. So language, the language we use when we talk to people about addiction. So they did a study in Harvard where they, this is in 2010, where they presented clinical scenario to 600 clinicians. Half of them, they described the person as a substance abuser, and the other half, they described them as a person with substance use disorder. And they found that the half where they'd use substance abuser as the term, people were much more likely to prescribe a punitive course of treatment rather than therapy. So a simple thing like that, just calling someone a substance abuser, or even an addict, because addict has come to have a pejorative sense. Rather than calling someone an addict, we can call them a person with substance use disorder. We talk about clean time. It's preferable to call it a period of abstinence. Those of you who are doing urine monitoring, you probably would never say this to your patient, but in the past, people would talk about having dirty urine, and rather it's an unexplained result. Drug abuse is substance use, of course, and even relapse is a very kind of all or none, black and white idea. And one of the things that helps people with substance use disorder is to get out of black and white thinking. So it's a return to substance use. It may be brief, it may be prolonged, but I kind of avoid the term relapse. So compassion never gets old. This is something that Ron Herring loves to say in his presentations, and so I borrowed it for this. And as I said, I think it's much easier said than done. You know, our ability to feel compassionate, to remain compassionate, depends on how we feel physically on what may be going on in our lives. If we have some disaster going on in our own family and somebody comes with a problem, sometimes it can be difficult to maintain that feeling of compassion. And people in active addiction can have some very challenging behaviors sometimes also. And I've really learned a lot in the past 2 or 3 years from my coworkers at Detox about maintaining this compassionate attitude. And some things that I found helpful have been, first, to separate the person from the behavior. People in active addiction behave in a certain way. When they're in recovery, they're totally different. When they're in active addiction, they're not behaving in a manner that's congruent with their system of values, really. And you're not able to see the person that underlies some of the behavior. To remember trauma, Jackie's talk, the phrase that I find really useful to ask myself is, what happened to this person? Not what's wrong with this person, but what might have happened to them in the past that could account for their behavior. A really helpful thing to remind myself. Remember shame, as Jackie talked about. Shame is the basis for a lot of the lying that goes on in addiction. So when physicians say my patient lied to me, it's because they were ashamed to talk about their substance use, or they were doing some sort of behavior that they were ashamed of. And then to remember that addiction is a brain disease. That was in that NIDA definition. And if we have a patient with Tourette's syndrome, we forgive them yelling obscenities in our waiting room. Or if we have a patient with dementia who is reaching out and pinching the nurses in the care home, we forgive that behavior. We don't think he's a dirty old man. We know he's someone with frontal lobe damage, right? But when people with addiction behave in a certain way, they're blamed for it, and that's the way our society treats people with addiction. But we're more enlightened than that, and we won't do that. So these are the things that have been helpful to me. The family physician's role, Ray talked about this, relapse prevention. It's helpful to look at the stages of recovery, and that graph that he showed was quite nice. The early on, that's the abstinence stage, where it's all just about not using drugs. And frankly, I think when I started working in this field, I thought that's what addiction treatment was about, was just getting people to not use drugs. And it's so much more. Recovery is so much more. And the abstinence stage is that middle phase that Ray talked about, where there can be changes in behavior. That's the phase where people are going through this kind of post-acute withdrawal syndrome. They can have variations in mood, variations in energy level, and can sometimes be misdiagnosed, as Ray said. A lot of the people that I see at Detox have been diagnosed as having bipolar disorder that don't have bipolar disorder. And then the repair stage, the repair stage is that middle stage where people are repairing themselves physically, which is what we can help them with as family doctors, doing that health maintenance work. And they're also repairing relationships, getting back to work, going to school, that sort of thing. So addiction is a disorder of stress intolerance, and what people have to learn in recovery is how to tolerate stress, learning to be comfortable with being uncomfortable. And that's something that we should be aware of as physicians, not to, that's their task, and not to be too quick with the prescription pad when they're complaining of anxiety, pain, and that sort of thing. So early on in recovery, cravings and triggers are very important, and in 12-step meetings they talk a lot about people, places, and things, which is sort of self-explanatory, I think. HALT, the acronym for hungry, angry, lonely, and tired. Those are times when people are more likely to relapse, and as physicians we should be aware of that. Other triggers to relapse at any time really, but especially early on in recovery: boredom, anger, family interactions, family reunions, that sort of thing. As physicians, we can prescribe medications that help with cravings. And I'm not going to go into the details about these things because we've done it before at other events, And there's some good references where you can look up the prescribing requirements for naltrexone and acamprosate. There's a couple of practical things. One is to just really encourage you to try these medications because they are as effective as lipid-lowering agents. They have a number needed to treat of somewhere between 12 and 20. So it's like treating hypertension. We don't hesitate to write a prescription for that or for lipids, and we shouldn't hesitate to give a try to naltrexone and acamprosate. Disulfiram or antabuse may have a role as well in selected patients. These things are covered under Plan G, but you have to, if you haven't already, is anybody in this room who hasn't completed a collaborative prescribing agreement for naltrexone? Okay, so that's in your package, and I'd really encourage you to fill that out, send it off. You only have to do it once, and once you do it, any patient that you prescribe for these medications is covered as long as they have fair pharmacare. It's covered under Plan G for them if they have low income. So that's important. The detailed information about prescribing these medications you can get in the BC Guidelines and Protocols. The guideline on problem drinking is really, really well written and has a lot of information. If you've not looked at it, I'd encourage you to look it up. It has information on this. It has information on ambulatory detoxification that Ray was talking about as well. And I'm going to say a word about that in a minute. And then for opioid use disorder, as family physicians, we can prescribe buprenorphine, naloxone. There's an online course that you can take through the BC Centre of Substance Use. It's 4 hours, and you get it's free CME for 4 hours of credit. You can do another 4 hours on methadone. Whether you're going to prescribe or not, it's still time well spent to learn about methadone prescribing. And that same organization has a 16-hour online addictions diploma course that I think would be worthwhile for anybody who really wants to learn a little more about the area of addictions medicine. Free CME. Now, I just wanted to show you this. For those of you who are prescribing buprenorphine or who have patients on methadone, I'd really encourage you to show them this pamphlet. It's available online. There's a copy in your folders. One of the things about opioid agonist therapy is that patients don't like being on it. They don't want to be on it. They don't want to start it. And once they get on it, they're in a big hurry to get off of it. And they usually want to stop it prematurely. In your package, there's also an opioid OHT tapering inventory, and it's a way of helping you to sort of assess where someone is in their recovery. Basically, it's not a great idea to taper OAT until somebody's in really stable recovery, and even people who are in stable recovery have almost a 50% relapse rate. So if you are going to taper it, don't just write a tapering prescription and say, see me next month. See them every week, ask them about cravings in an open way, open, non-judgmental way, and you may decide to slow down the taper. I wanted to leave you with one other practical tip. So explaining anti-craving medications to people can be really challenging sometimes, and talking to them about opioid receptors and the midbrain and that sort of thing. I just see their eyes glaze over. I do it a lot in detox. So one day I decided to try a new model to explain it. So this is it. And when I start talking about the angel and the devil on the shoulders and tell people that naltrexone makes the angel louder and the devil quieter, they understand that. They see that and they laugh, and it helps them to accept this as a medication. They understand that it just quiets down that internal voice, the internal cravings. So you can try that if you want. But okay, cross addictions and concurrent disorders. It's important if you're dealing with people in recovery to know that these things exist, that people who have a substance use disorder often will have one of these other things: gambling, shopping, pornography addiction, internet addiction. Eating disorders in detox it feels like sometimes half the people we have there have eating disorders, but they're the top 0.6%. And anxiety disorders and depression, of course, are really common, and it's very important that they be properly treated, that people be referred for treatment if necessary. When I ask people about some of these process addictions, as they're called, the gambling, shopping, and whatnot, I think it can be shaming to even ask about those things. So I normalize it and say many people who have addiction have problems with these things as well. Has any of these ever been a problem for you? And that shows that I'm not going to judge them about this. And I think people seem to respond well to that. So let's see, what do we got here? Recovery supports. I don't have to say too much about that. We've got half of them here. Ray mentioned the Caduceus group. If you have any physicians in your practice who are in early recovery, just contact one of the addiction medicine physicians in town, and we can put you in touch with the local Caduceus group. There's a Buddhist recovery group. I didn't know about that, but that will appeal to some people. And support for families is, as Ray said, is very important. I think it's a big lack in our treatment system that we don't have formalized reports for people in for the families of people in recovery. I've recently started recommending this book, Beyond Addiction, for family members, and it's really very complete. It sort of outlines the community reinforcement model for families dealing with family members with addiction, and it makes them part of the solution. It gives people guidelines. Thanks, Chrissy. Chrissy tells me to shut up. So we'll rush through those last few slides. There's Island Health Services. I wanted to put in a plug for CBT skills groups, and not just because Aaron's here, but because I think that anybody in recovery who's still struggling with anxiety, shame, guilt, CBT groups are going to be very useful. Relapse can occur at any time, and I did want to make the point that these stressful life events are common causes of relapse. Lots of people we get in have relapse because a relationship broke up, a parent died. I just heard a statistic last week. I haven't verified it, but I learned that 1/3 of seniors who have alcohol use disorder developed it after retirement or in later life anyway. And so as family physicians, we can do a lot in terms of preventing the development of substance use disorders by monitoring people and meeting with them when they're going through some of these life changes. I'm ignoring you, Chrissy. So responding to relapse quickly and with compassion. Relapse is a learning opportunity. If detox is necessary, send them. If you're going to do an outpatient detox, please do it properly, as Ray did, by having the patients come back every day and monitor them, not just giving a tapering prescription for Valium. And look at the BC guidelines. They have a tapering or a detox protocol, and pay special attention to the contraindications. There's many, many people who aren't suitable for outpatient detox. And then if people relapse, you can intensify treatment. You can add in anti-craving medications. Make sure they get back in touch with their supports or increase their supports. So, in summary, for about the 12th time today, addiction's a chronic disease. Family doctors can play an important role. Relapse is common and can be a learning opportunity. Attitude and language are important. And I'll just leave that slide on. This is from the Human Systems Dynamics Institute. And I think it speaks to what Jackie was talking about, that attitude of curiosity. You'll get a long way with that in any tough situation with patients. Okay, thank you. No time for questions.